So hi, dear students. We are going to have a lecture on neurological diseases and surgical procedures with physiotherapy management. So uh, today we begin the neurological disease with surgery. Mm, what is neurological? That means we are going to discuss about the functions of the brain, spinal cord, and nerves. How is it affected? And what are the we as a physiotherapist do after surgery to prevent the complication and restore the independence? So I would say surgery may relieve the problem, but the physiotherapy will restore a function. So this is how I would ask you to put an attention to. So neurosurgery is a branch which will be dealing with the disease of the brain, spinal cord, and the peripheral nerves. In our clinical practice, the most neurological and surgical patients are show a five broad issues. Okay, these are the motor impairments, sensory loss, abnormal tone, bladder and bowel dysfunction, overall functional disability. These are the exact domains which a physiotherapy will target. If we ignore any early rehab, the patient may develop complications like contracture, pressure sores, uh, I would say chest issues. So that would be long term, and patient might be dependent due to the lack of rehab, right? So this is what we expect that our patient uh, fully restores its function, right? Let's go to the next one. The nervous system which controls muscle contraction, movement, posture, sensation, bladder, uh, that bladder functions that may neurophysiology will matter to us because it allows a safe rehab planning. If you know the pathways, you can interpret symptoms correctly, right? Weakness pattern you can interpret, the changes in tone, sensory loss, and we can decide what is safe to mobilize and what is must to be protected. So it converts a symptom into a rehabilitation plan. That is what we need, right? If a patient has a weakness with increased tone, so what do you think? The lesion may be upper motor neuron or a lower motor neuron. So that is what we need to understand, right? So let's go to the next slide. Muscle tone. It's a normal resistance that you feel during the passive movement. It is not a strength that's maintained by stress reflexes. As we had discussed earlier, the gamma motor neuronic activity, right? And its balance between the excitatory and inhibitory brain signals. Normal tone is essential for the posture and movement because without the tone, you cannot hold joint stable. There will be laxity. Now, I would not say laxity, but joints cannot function well without tone. I mean, it will give away. With too much tone, movement becomes very stiff and efficient and inefficient. We had discussed earlier that the higher the tone, the limb will feel lighter weight because it is holding all the joints together, and it is very taut in nature. It is very stiff in nature, right? So we should broadly understand that tone is a resistance to a passive movement, and it cannot be considered as a power. It cannot be considered as a strength. But the tone is necessary for the posture and the functional stability. That is for sure, right? Now, let's categorize its disorders. Now, let me say uh, there are the key tones disorders. I mean, there are total of three, which are the disorders of tone: spasticity, flaccidity, and rigidity. Right? This is the rigidity. Spasticity is increased tone and it is velocity dependent. That means the faster the stretch, more the resistance you'll get, right? And it is in commonly upper motor neuron lesions. Flaccidity means there is a decreased tone, or sometimes it can be absent. It is the soft feeling when you are touching a muscle or when you are doing a passive movement of the particular muscle group. That means joint, which is generally seen in lower motor neuron disorders. Okay. Next is the rigidity. The rigidity, that is, I would say, it's a uniform resistance. Okay, through the range. That means from the starting of the movement of the muscle till the end of the muscle movement, throughout those range of motion, you will feel the resistance. That means it's rigidity. And generally, it is due to problems in the extrapyramidal tracts, right? So I would say clinically, it affects the positioning, transfers, gait training, and risk of contracture. So we don't just observe tone, we treat its consequences as well, right? So understand the tone, the pattern of tone. It helps localization and the management helps the function. That means if we can manage tone, we can get the function out of the joint or a muscle or a limb. Okay, so that is what is understanding. So let's understand how the tone it influences the posture. So as you can see, the posture, right? There is a given a correct and incorrect posture. Posture is an alignment of the body segment. It is against the gravity so that we can stand, we can sit. It is maintained by muscle tone, not only the tone, but also the proprioceptions, right? That means these are the receptors which are present in the joint, which will tell us the position sense. Okay. Uh, so along with that, there is a vestibular input which is present in the vestibular system. Abnormal, any injury, okay, any injury or any damage or any disease or disorder, uh, that would have an impact on muscle, and thereby indirectly it would impact on posture. So the posture becomes abnormal due to weakness of muscle, spasticity, or a balance issues. Poor posture, it is not a cosmetic thing. It leads to deformities as well. Posture, uh, the pressure points due to abnormal posture would cause a source to that particular area where the pressures are more. Inefficient breathing mechanics would happen if the patient is too much stooped posture, okay, or maybe any one side bending is happening, and that would also lead to a poor movement quality, right? So consider, have it in mind that posture is a platform for movement, and if a correct posture is there, it is easier for the functions and there will be a fewer complications. So whenever a therapist would engage into emphasizing posture, they should keep these things in mind. Okay, but along with this, motor and postural issues, neuro patient often develop a bladder control. So let's see next about bladder. Normally, the bladder control requires a coordination between the brain and spinal cord. Okay, because brain considered as a voluntary control and spinal cord considered as a reflex control. That means a reaction or a response. And peripheral nerves, which are necessary for the sensations and which are necessary for the contraction of that particular region. Okay. So when this pathway is disrupted between brain spinal cord or spinal cord to peripheral nervous system, uh, we will be having a different kind of issues at bladder, and these are names are reflex bladder. That means automatic it will empty. Okay, automatically it will empty. I mean, only small amount of the bladder or a mid or moderate amount of urine is collected, and it may just have a sensation. It will go into emptying the bladder. Okay. Next is flaccid bladder. That means to the extent point, to the last point, the bladder will keep on filling, 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 unless until it gives away, and there will be a leakage of the urine out of the bladder. That's dribbling of urine. Okay. And the last one is uninhibited bladder. That means even the smallest amount of urine is collected, it will straight away empty. That means it's an urgency of the micturition. So for us, the bladder is a dysfunction which affects the rehab scheduling. Uh, Maybe psychologically patients having might be embarrassed, or there'll be a dignity issue, so that the confidence on in during the rehab program would deteriorate due to bladder function, and we can explain and we can counsel a patient about this is perfectly fine. Okay. And of course, due to bladder issues, there will be a um, chances of complications like urinary tract infections and so on. So we should understand that bladder status, it's a important functional assessment, and it's not a afterthought that we can deal with later. Okay, so we should be always uh, assess first whether the bladder is affected or not, and if it is affected, we should plan appropriate assessment on it. Okay, so let's move to the next part. Just consider the movement. Okay, and the beginning of the movement. That means when the movement starts, the motor cortex will be planning, and then only the movement can occur. Okay, so there will be a plan of movement, and the movement will happen. And this command of moving, I mean, we want to move a part of a limb, so that command it travels via the corticospinal tract, and it will activate the all motor units. And if any of the part of those command traveling is damaged, then we can see a loss of coordination between the limb and joints, and there will be weakness. So it is this rehab. It is not only strengthening its motor control retraining, and but also it teaches the nervous system to produce an efficient movement again. Okay, so this is how we should understand. So rehab program, it is motor learning, and it is not just a part of exercise or exercise program. So we are relearning. Our body has been relearned of doing a motor movement. So this is what we need to know. Now let's move on to the next segment. Pain in neurological patient can be nociceptive due to tissue injuries, neuropathic due to nerve damage, and radicular, that means radiating pain due to nerve root issues. So pain affects the mobility, participation in our rehab program or a physiotherapy, and it also affects the overall recovery because patient will be most sensitive towards the pain, and that is what is keeping the patient from doing exercises or obeying the commands of any the therapist during the program. So clinically it is our job to identify the type of pain. uh, we would go for the precautions in managing pain or reducing the pain or limiting the pain, and we modify the therapy to keep the patient active without provoking any symptom like pain, right? So if the pain is uncontrolled, rehab will become limited. That is what is for sure. So the pain education and graded activities are really essential for a physiotherapy participation, right? So now let us go towards the All neurological diseases, important ones which are happening in childhood. So we are going for congenital and pediatric disorders. So congenital neurological disorders, which are conditions which are present at birth, usually due to development defects or failure of neural tubes closure during the development stage. Which means that infant or sorry fetus is been uh, being born or being developed in the mother's uterus. Right? During those time only there is a problem. There is a failure of developing appropriate. So there are mainly two common conditions that you must remember, which are hydrocephalus and spina bifida. These disorders which affect the motor control, that would affect the sensations and bladder functions, and it also affects the oral function of the baby. So in congenital conditions, the disabilities that will progress if there is an intervention is delayed. If there is a delay in intervention, that would worsen. Fine. Let's go to the next. It is defined as abnormal accumulation of the CSF, which is present in the brain ventricles. So what happens basically, CSF is building, 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 and there is no resorption of the fluid. So that leads to increased intracranial pressure, enlargement of the head in the infant, and compression of the brain tissue would happen due to enlargement of the ventricles. Okay. So please remember that the brain compression is the real problem. The fluid accumulation is not a problem. Okay, brain compression is a problem that is leading to the neural death. So to understand this, we need to know the what happens inside. So what happens inside a brain? So when an excess or an extra CSF is accumulating, the ventricles would dilate. Presence of increase in pressure that would create a the pressure will be building up on a brain tissue. So the cerebral spinal fluid that would affect the blood flow. That means the obstruction happens. Okay, and this obstruction, because the too much pressure is there on the blood supply, so there will be obstruction to the blood flow. So blood flow reduces, that will obstruct again the CSF flow, that is cerebrospinal fluid will be again obstructed, and this obstruction will not allow CSF to clear out. So there will be impaired absorption of CSF, and it is rare to have an excess production due to obstruction of the CSF flow. So reduced blood flow meaning the reduced oxygen, and that's why nutrients would be reduced toward the brain. So there is no much supply of nutrients to the brain. Okay. So consider this hydrocephalus meaning it's a pressure on brain and perfusion. That means blood supply and the absorption of the material, everything is problem, right? So now what happens clinically, let's discuss in the next slide. So in infant, features like enlarged head, bulging fontanelle, delayed milestone would we would see. So delayed milestones like whatever the age appropriate milestone that baby uh, achieves during birth, after birth. That means, able to get up from the supine line, able to put hands towards the floor and, get up, having a neck control, ability to speak, ability to walk, ability to get up from the floor. So these are the milestones that baby should achieve, which is supposed to be age appropriate. So that would impaired. So in older children, the symptoms would include like headache, vomiting, visual problems, and gait disturbances would be happening. So age, which will matters because the skull bones are flexible only during infancy. Okay. So always there should be a differentiation between the infant and older children differentiation that we should know that in infant hydrocephalus is this, in older children hydrocephalus would lead to this features, right? We should know this. Now let us understand the surgical management. The surgery which will aim to reduce the ICP, that is intracranial pressure, and further prevent a brain damage. So there is a VP shunt or ventriculoperitoneal shunt will be done by the surgeons, and which will divert the cerebral spinal fluid from brain to the abdomen. Endoscopic third ventriculostomy that would create an alternative CSF pathway. Both aim to normalize the pressure. So this shunt, which save life, but it has a long-term complications, right? This shunt can be able to relieve the pressure and everything. So this complications, whatever complication is happening because of the not the procedure, but also for the but due to the disorder like hydrocephalus, the physiotherapy management should be done to prevent those complications or to manage those complications. So it focuses physiotherapy management. It focuses to positioning to prevent deformities, facilitating normal movement pattern, developmental exercises, and balance and gait training. So constant monitoring should be done on the shunt complications as well, like headaches, vomiting during the program, or we should educate to the parents as well about if at all if you observe these symptoms, we should be notified, and the therapist would communicate with the treating doctor. So we are treating the development, okay? Being a physiotherapist, we are developing a child that by giving rehab program, and we are not just providing exercise. Exercise meaning we are enhancing the development. Okay, this is what it is. Now let us understand the next disease, which is spina bifida. So it is a congenital defect where the neural tube which will fail to close, leading to exposure or a malformation of the spinal cord. So the severity of the spinal cord depends on the level of or the type type of defect. Okay. So we can see the higher the lesion, greater the disability. So let's classify. You already have an idea about this as I had taken the lecture till spina bifida in class. So types are spina bifida occulta, which is hidden in the minimal symptoms. That means sometimes it is not quite early that a patient would come to the doctor, and it is generally asymptomatic or with minimal symptoms. Meningoceles, it involves the protrusion of meninges, and myelomeningioceles, that means it's severe type where the spinal cord and the meninges will protrude itself. Okay. So consider myelomeningocele is the severe form, and maximal neurological deficits will happen. Okay. So what happens to the tissue, neural tissue, we'll see next. So the damage to the neural tissue causes motor weakness, sensory loss, and bladder and bowel function would also be affected. Higher the lesion, which will produce more severe disability. So motor level, which will determine the mobility potential. If the motor level is higher, mobility deficiencies will be more. If the motor level or a damage level is lower in the spinal cord, the mobility issues will be lesser. Okay. So let's see its clinical features. The patient may present with a paralysis or weakness of lower limb, deformities like cleft foot or scoliosis, sensory loss, urinary incontinence, and eye infection risk. This deformity is a prevention. That means that the deformities prevention is to which should be a lifelong goal, like a clubfoot or a scoliosis. That means a patient should be engaged and should be able to do the exercises to prevent those deformities, because deformities might happen due to abnormal muscle tone, and this is what is to be prevented. So it is a lifelong goal. Okay. Now, what are the management that is required of these features? We should know. So surgery, which will involve only closure of the defect, okay, and prevention of infections. Physiotherapy will include positioning, pressure sore prevention, all the range of motion exercise of the limbs, strengthening of whatever the available. That means available muscles. That means whatever the muscle which are been already present and doesn't require any kind of management. So what can we have a management on those muscles? Okay, that means strengthening the muscles more and gait training with those muscles with orthosis, that means external aid, and functional activities of daily living, the training of those, and education to parents, because the parents are a part of rehabilitation team. We cannot just teach a child and our job is done. It's not like this. So with this, we are concluding the children or pediatric disorders. Let's go to trauma. So trauma, it's an it's considered that unlike any congenital disorder, trauma is always sudden. It is unexpected. Okay, it may sometime be life-threatening also. So let us move to the next one. So neurological trauma or a neurotrauma, it refers to injury to the brain, spinal cord caused by any external force. Trauma which will lead to structural damage, secondary swelling due to damage, and compression of the neural tissues due to swelling. Due to these things, functional loss will happen, and severity and duration of the compression would also lead to how much functional loss is happening. Okay, so primarily the injury happens to the brain or a spinal cord, which happens instantly. Secondary injury, which will evolve due to primary injury, that is trauma. Due to trauma, primary injury happens, but secondary problems will happen due to the severity of injuries, and that secondary issues which are preventable by physiotherapy or a surgery. Okay, so let us understand the injury level. Okay, in the next slide. So clinical localization meaning identifying the injury level based on its symptoms. Like brain injury causes altered consciousness and cognition, but a cervical spinal injury causes the quadriparesis. Thoracic or a lumbar injury causes the paraplegia. So the nerve root injury causes the radiating pain and dermatomal weakness. Dermatomal weakness meaning weaknesses of sensations. So these are the levels of injury. If it is represented during assessment, we should start the program as per the level of injury. So we should always correlate the symptom with its anatomy. Okay. Now understand the head injury. In the head injury, it impacts, causes a brain movement inside the skull, tearing the blood vessels. I had given you in the class the examples of the road traffic accident, and due to that, there is a forward and backward movement of the brain. So, tearing of blood vessels will happen, brain edema will happen. Since the skull is rigid, the swelling which will increase the intracranial pressure. Due to this pressure, which is really dangerous, okay, and it alters the cerebral perfusion, as we had seen in hydrocephalus case. So this swelling inside, it is a swelling inside a closed block box, and the compression to the brain occurs, okay, which is dangerous. So consider there are two types of head injuries, primary and secondary. Let's see in the next slide. So primary injury, it occurs Immediately, contusion and laceration will happen. Secondary injury, it develops later due to hypoxia. Due to a primary injury, secondary injury happens. The injury might be hypoxia, edema to the brain, increased risk intracranial pressure, and these secondary injuries can be preventable with appropriate surgery or a physiotherapy. Okay, so a good positioning and early mobilization which will help reduce the secondary injury by a therapist, and surgeons will do its part. Let's see about the immediate care which patients should receive. So the first aid, which aims to prevent secondary brain injury, which will maintain the airway, breathing, and circulation, which will immobilize the spine, avoid the hypotension and hypoxia, transport the early trauma center. Okay, transport to the trauma center. That means ICU in our case. Physiotherapy. Poor early handling. Okay, that means while carrying a patient from a site of injury or a site of trauma to the stretcher or in the ambulance, the way of method of carrying a patient should be carefully done, because any malhandling during this uh, positioning or transport would cause more injury, and this is what happens. You know, the trauma, the injury occurs due to trauma would be less, but the type of carrying, the method which were used to carry a patient, which will cause more damage. Okay, so that has to be prevented, and those first aid caregivers should be educated appropriately, right? So now let's see what the surgeons will do. The surgeons, they will do a craniotomy, involves the opening of skull, and it removing the that involves the removing of clots which is happening due to the blood vessel infarction. It will decompress the brain because the swelling will go away as the cause is removed. Decompressive craniotomy, which will remove the bone flap permanently to allow the swollen brain expansion. Both aim to reduce the intracranial pressure. Decompression will save the brain tissue. It will let it swell, and after the cause is removed, the swelling will come back to its normal shape. So brain will come back to its normal size. Even after the surgery, patient may face a long-term issues. Okay, because of that. So let us understand what sequelae of the head injury. That is a long-term effect include a persistent weakness, balance, coordination deficit, cognitive impairment, and behavioral changes. Rehab program is a long-term and multidisciplinary. That means everyone should be engaged in treating a patient. So physiotherapy should begin immediately post-operation. That is what is needed. So let us see physiotherapy. So post-op care or post-operation care, which includes the positioning of the patient, ICP precaution, that means head should not be placed down in tilting whichever positions are given. A therapist should always take care that the head down position is prevented. Instead, the head elevation more than 30 degree is suggested. There should be range of motion exercises, bed mobility, sitting balance, gait training, and functional task relearning like ability to walk, ability to eat, ability to comb hairs. These all functional tasks are there, and the therapist should be engaging the patient into learning those tasks. Okay. Now, what happens in the spinal cord injury? Let's see. So it occurs due to the direct cord damage or a compression by the bone or disc. It interrupts the nerve signal translation, causing the loss of movement, sensation, or loss of autonomic function. That is called as autonomic dysfunction. Okay. So these are the spinal cord injuries. That means trauma to spinal cord. Head we had completed. Now we are going to spinal cord. Now let's see what is the acute management with the spinal cord injuries, which is aiming to prevent the further cord damage. Okay, immobilize the spine, prevent the hypotension, hypoxia, perform the surgical stabilization if at all, if it is required. Okay, now we'll see what surgeons do. They do a decompression. Okay, which means removing of bone or a disc from the compression site, and this is how they will decompress the spinal cord. Stabilization, which will be done with the screws and the rods. As you can see here, there are screws and rod fixation is happening. Okay, and plates also can be given to prevent abnormal movement. Okay, so that that part will be rigid enough. And what happens after surgery? It is our self, that means our role, therapist role. What the therapist will do, let's see. Post operation physiotherapy, which will include respiratory exercises. We need to prevent the respiratory complications. So yes, respiratory exercises should be given. Pressure sore prevention, as we all know, that part will not be having any, I mean, the limbs will not be moving on its own. I mean, patient will, might not have a voluntary control. That means the, if at all, if any limb is been kept in whatever position, that will remain in that position, and patient will not be having a control over that. That will increase the pressure over the pressure points wherever the patient is lying, that part has been lied on. So we need to relieve the pressure over the pressure points. That means suppose a patient is supine lying, that means a pressure will be more over the buttock area, pressure will be more over the olecranon process of elbow, pressure will be more over the heel area, pressure will be more over the occiput area, pressure will be more over the shoulder area, that means the spine of scapula. So these are the things that will be high in pressure, and we should change in positioning frequently. Okay. Uh, Other than that, transport training should be done once the tone is improved. Wheelchair skills should be given. Endurance training should be done once the muscle control, we gain the muscle control. Okay, so that will, this rehab program, which will restore the independence of the patient, that may not restore the nerves. Okay, but somehow we are finalizing, or we are improving the functions of the patient with the available muscle that we can train. Okay, now let's move to the trauma disease process. So these are the spinal cord disease. Let's see what are the spinal cord diseases. These are the spinal cord problems, or a disease of spinal cord, which will cause a progressive compression, ischemia, which will lead to motor weakness, which will lead to sensory loss, and which will lead to bladder dysfunction. Okay, this is what is called as. So one of the important group of this is CVJ abnormality. Okay. So CVJ abnormality or craniovertebral junctional abnormality. It is between the skull and the upper cervical spinal cord, which will cause the brainstem or an upper cord compression, which will lead to a breathing difficulty, weakness, and gait instability. That means this is the highest of the spinal cord junction, which will be affected due to compression or a trauma, and due to that the whole body muscle dysfunction would happen. Okay, even the breathing abnormality would happen because it is affecting the pneumotaxic or apneustic centers, which are available in the brainstem and medulla, right? So what are the surgeries? Let's see. The surgery of those involves the decompression and fusion of the stabilization and fusion to stabilize the and prevent the abnormal movement. Okay, this is what is that. Now let's see what are the other diseases. So let's see about syringomyelia. So syringomyelia, it's a fluid-filled cavity which will form inside the spinal cord, destroying the central fibers, causing loss of pain and temperature with a muscle weakness. This surgery, uh, there is a surgery for that. Okay, so what is the surgery? Let's see. What do we do? So whatever the cerebrospinal fluid is there, we need to drain that. Okay, so we are draining the syrinx or a cavity. Okay, syrinx meaning cavity. So we are draining it. Okay, so this is how we treat it. and whatever the malformation happens, and we are actually decompressing due to that compression. So example is Arnold Cherry malformation, which is just for knowledge purpose. There's a one type of featured disease which will happen because of syringomyelia. Okay, cervical and lumbar disease, disc herniation that will compress the nerve root, causing the radicular pain, or the spinal cord causing the myelopathy. Myelopathy meaning muscle problem. Now let's move to the another slide. This is the discectomy. This slide that means what is done during these syringomyelia and disease. So we do a discectomy, that means removal of the disc materials. Laminectomy, uh, removal of the lamina, and there is a fusion. If the uh, vertebral column is not stable, that means there are comminuted fracture or something, then it will fusion will be done so that the upper and lower vertebral bodies will be fused together with the help of the plates and screws. Okay, so that will prevent the instability. Now let us know about the tumors of spinal cord. So this tumors compresses the neural tissue. It will gradually causes a progressive neurological deficits. What happens? Similar to the hydrocephalus or something, there was an overall brain which was compressing due to the higher cerebrospinal fluid. Here, the part of brain is been compressed due to the abnormal cell growth. Okay, so let's see what are the surgeries for. Obviously, remove the tumor. Okay, so this involves tumor excision. The goal is to relieve the compression and preserve the function through the tumor excision and the stabilization. Okay, what is the physiotherapy? Physiotherapy is spinal precautions, log rolling, gradual mobilization, range of motion, strengthening, and gait training. Let me tell you again. We had already discussed about the log rolling. Log rolling is uh, changing the position from supine to side lying in such a way so that patient's body is not twisted. Okay, which means when the shoulder are coming into a side lying position, with the simultaneously even the hip should come into the side lying position. That means not first shoulder and then hip. There, that way the body will be twisted. Instead, the whole body should come into side lying together. That means it's a log rolling. You can see the YouTube videos on log rolling technique, okay, which are easily available on internet. Now let's compare the trauma versus the trauma is sudden, it is emergency based. Disease is gradual and planned. That means disease will be progressive. Okay, disease will never be a uh, uh, um, instant. Okay, and we can plan a surgery. Here trauma requires emergency surgery, but disease requires a planned surgery. Okay, and the rehab principle which may overlap, but the progression of due to trauma and progression of the progression meaning recovery due to trauma and recovery in disease which will be different. Okay, so the role of physiotherapist is to prevent the complication, that is secondary complication due to primary injury, restore the mobility, improve the independence, and educate a patient and family. That is what is our goal. So, if we consider this is where we are completing the trauma. So, consider that compression, which will causes the symptom, surgery will relieve the pressure, and physiotherapy will ensure the long-term functions. Okay. That means we are focusing on long-term recovery. This may this may not take any uh, acute growth. That means while you are doing physiotherapy, you may not receive uh, uh, very early recovery in patient. Okay, it might take months and years to gain a single function also. So basically, keep on doing the right way posture and keep on educating a patient in a right way. Keep on remind families to uh, give appropriate care to the patient and educate patient himself that aligning your joint while they are not in function or till the time you have not gained any recovery or voluntary activity on that muscle group, you need to keep the muscle in an appropriate position so that it might not lead to contracture or tightness or any deformities like this. Okay, so this is what is the injury related things that we can take. Now we should go for the peripheral nerves. We had completed head, we had completed spinal cord. Now let us go to the peripheral nerve. So let's consider understand about the peripheral nerve, right? So peripheral nerves disorders, these are consider that it is outside of the brain. Okay, peripheral nerve are outside of the brain and outside of the spinal cord, and these are commonly occurring problems at peripheral nerves, okay, due to trauma or due to diseases. Okay, so peripheral nerve disorders can be considered as peripheral nerve injuries, okay, due to disease or anything. Okay, so let us understand this. Peripheral nerve, it will carry a motor fiber for the movement. It will carry a sensory fiber such as touch and pain, and autonomic fibers such as sweating, blood flow to the skin. Okay. The simplest example I can give you is during a panic attack, your hand becomes numb and hand becomes cold. Okay. Your palm may be sweating like a lot. So this is what is autonomic function, okay, of a body. So during peripheral nerve injury, there is an autonomic dysfunction. Okay, such function may be disrupted. Injuries to the peripheral nerve causes weakness, sensory loss, and the functional disability. Broadly, we can classify them into nerve injuries and entrapment neuropathies. Entrapment meaning something has been occluding, something has been entrapping or encompassing or obstructing, okay, or compressing. This is what is called. So understand peripheral nervous injury. Peripheral nerve injury, that means there is a problem in movement, sensation, and functional activity will be affected. Functional activity is affected. Okay, now let's see when a peripheral nerve is injured, what happens. So any trauma to a peripheral nerve which we can cause a conduction block. Axonal disruption will happen. Okay. As a result, a patient develop a muscle weakness or paralysis. Sensory loss, like tingling or sensory loss, complete absence of sensation, and denervation changes like a muscle wasting will happen. So this denervation, meaning denervation of muscle, that means no nerve at muscle area, that will waste the the atrophy will happen at the muscle area. Okay, so this wasting will tell us the injury is more severe or prolonged one. That means then only denervation will happen. Okay, so to understand the severity, let's classify the nerve injury. So the Saddle's classification is there. Please consider, and if you have not read, please read the anatomy book and applied anatomy for this. Okay, please read the applied physiology. Saddle's classification, which are nerve injuries into neuropraxia, exenotemesis, and neurotemesis. Neuropraxia is a temporary conduction block with a full recovery. Praxia meaning compression. Okay. Exenotemesis, which involves the axonal damage, but the sheath is intact and the recovery is still possible. Neurotemesis is the severest type. That means it is a complete nerve which is cut. Okay. Neurotemesis will never recover without a surgery. Okay. Because the two ends which where the cut happened has to be rejoined, reanastomosed. Okay. So the how to localize this injuries. Okay. So clinical localization, which will based on the pattern recognition. How do you pattern? How do you recognize a pattern? We look at which muscles are weak. We look at which skin area has a sensory loss. Whether the reflex changes is present or not. That means tendon reflexes, deep tendon reflexes. Provocative tests are to be performed, and typical deformities are observed. This allows a diagnosis without investigations. That means imaging or something. So, if you know the anatomy, hand will tell us the story. Like claw hand. Okay, it is the best example that we can see. Now let's see the classical nerve examples. Like what happens in radial nerve injuries. When the radial nerve is injured, there is a loss of wrist and finger extension, which will produce the wrist drop. Sensory loss will occur, and sensory loss will occur at the dorsum of hand, uh, which will also be at the web space of the thumb. And by functionally grasp, any grasp will be poor, or there is a weakness in grasping anything, okay, like bottle or a ball or something. So because the wrist is not stable and it is giving away. So wrist extension is essential for a power grip. Otherwise, it will not hold any object. Okay. Now let's see what happens in the another nerve. Median nerve. Median nerve injuries, it is thinner muscle of the palm is weak, leading to thinner muscle weakness. It will reduce the thumb opposition. If you have an opposition function, that will be reduced. That means that will be weak. Opposition will be weak from thumb to any finger. There will be a sensory loss at the lateral three half of the finger. And functionally, patient will struggle with the pinching activity, buttoning activity, or any kind of fine motor movements like writing with a pen holding or something. Okay, so this will be this problem. So broadly, you consider that median now, if affected, then opposition movement of thumb will be affected. Next, when the ulnar nerve is injured, it is causes the androsia weakness. That means sensory loss at the median nerve and the half fingers. Clawing of hand happens. As you can see in the image, the last two fingers here are flexed. Okay, the middle finger is half flexed. This is what is considered called as claw hand. The hand becomes claw hand, but the half only. So clawing occurs due to the intrinsic muscle weakness and causing the MCP hyperextension, okay, and interphalangeal joint flexion. This is what is happening. So ulnar now consider as intrinsic hand function is ulnar nerve injury is causing the intrinsic muscle problem. Okay. Now let's see the surgical management of this. If the nerve is intact, the surgeons may observe with the splinting and physiotherapy rehab is done. But if there is a neurotemesis, that means cut, the surgical repair, it includes the neuroraphy, that means repair. Nerve grafting, that means another part of the nerve has been grafted there. Or nerve transfer should be done. And late cases, that means if the injury is done earlier but no treatment till now, and in those cases, late cases may require a tendon transfer so that we can reteach the or a muscle group can relearn. Okay. So during these, what are the physiotherapy after nerve? Initial phases which will focus on the protecting, repair, immobilization. Immobilization is must, okay, during the initial phase. Edema should be controlled. That means we can manage edema. Safe adjacent joint movement. Later phase, which will include the progressive range of motion, strengthening, and functional retraining ultimately. So, a nerve stretch can also be done. We will learn it later in the later semesters, like seventh and eighth semester, how a nerve can be stretched. So let's see the sensory aspect. Okay. As the sensation will return, the sensory re-education, which will include the touch localization, that means we will ask the patient, we will train the patient, where did I touch, okay, with the cotton wool or any other object. Texture discrimination, rough surface and smooth surface, okay. Stereognosis, if the hypersensitivity increase, then the desensitization is done using a graded textures, okay. Desensitization meaning you are actually reducing the sensation feedback by actually giving sensation differences, okay. By providing the different kind of sensations, we are actually reducing the hyperactivity of the sensations, right? That is called as desensitizations. Now we should move to the entrapment deformities. So entrapment meaning nothing but a compression. It's a chronic compression of a nerve in a narrow tunnel, which will reduce the blood supply. It will cause swelling, pain and numbness and weakness of the muscles. This compression can cause ischemia, that means reduction in the blood supply. And this ischemia will lead to symptoms. Okay. What symptoms can be there? As we all know, pain, numbness, and weakness of muscle. Carpal tunnel syndrome is one of the entrapment syndrome. It's a compression of the median nerve at rest. Features include night pain, tingling to the thumb and middle fingers, weakness of the thumb opposition, and dropping objects. That means we cannot be holding a object with a power or with a strong grip. So early intervention which will prevent the permanent thinner wasting. If at all, if we work with the thumb nicely, we can prevent the thinner muscle wasting. Okay. So another entrapment syndrome, let's see, cubital tunnel syndrome. Cubital tunnel syndrome at the elbow we are talking about. Cubital tunnel syndrome, it involves the ulnar nerve compression near the elbow. Symptoms include the tingling in the ring and little finger, hand weakness and intrinsic muscle wasting in the later stages. In bridges, what can we consider? What if at all, if the conservative care is failed, what surgery can be done? I mean, these are the cubital tunnel syndrome and carpal tunnel syndrome can be done without the surgery. Okay, the rehab program can be done without surgery. But what happens when it requires surgery? Okay, so in what cases? With these entrapment syndromes, a surgical intervention will decompress the compartment, okay, and neurolysis frees the nerve from the scar tissue. Neurolysis meaning we are cutting the problem nerves, okay. So release the adhesion of the around the nerve. So that is what is happening. So what are the physiotherapy after surgery? Early phase, which will include the edema control, gentle range of motion, and scar care. Okay, the scar mobilization we had learned during the practicals. Later phases, which will include the nerve gliding, strengthening, ergonomics, and activity modification. For now, you just remember nerve gliding as one of the management in peripheral nerve injuries. Okay, in during the neuro subject, you will more learn about what are the nerve glidings. Okay, so this is what is the thing. Okay, uh, so being a physiotherapist, we should always look on the prevention of complications due to injury or after surgery. Okay, this is what is very much crucial. Now let us see the next disease. Now we are talking about the tumors which will rise from the brain tissues. Okay, so intracranial tumors, which are uh, which can happen in meninges, cranial nerves, pituitary region, or metastasis, meaning which will spread. Okay, and location of the tumor will determine the symptom based on the location of the tumor. Okay, so broadly classification, if we do, tumors are classified as primary and secondary, benign or malignant. Benign meaning which will not be spreading towards the other parts of the brain or other parts of the organ. On malignant meaning it is spreading. Supratentorial and infratentorial. Okay, so let us consider uh, the physiotherapy management in tumors. Tumor can cause symptoms like a by mass effect, like a raised intracranial pressure and focal dysfunction will happen. Okay, so which means whichever the brain area is been targeted with location, that area function loss may happen, or functional or dysfunction will happen. Even if the function is persisting, that may altered function. Okay, like if the ICP is raised, then the typical sign of increased ICP is headache, vomiting, papilledema, and altered sensorium. These are the things that we will see. And raised ACP, raised intracranial pressure, it's a medical emergency. Okay. Now let us see the next one, that is focal neurological signs. The focal signs are motor cortex lesions, which will cause a contralateral weakness. As we all know, there is a decussation of the nerves, right? So, more contralateral side weakness will happen if the brain area of the right side brain is affected, then the left side weakness will happen. Speech area, which will cause aphasia. Okay, if the tumor is located at the speech area, that will cause aphasia. If the cerebral lesions are there, then ataxia, and the brainstem is affected, then cranial nerve will be dysfunctioning. Seizures may be a first symptom of cortical tumors. Okay, seizures will happen. And post-operative seizures precautions are essential during the rehab. Even the after operation of removal of tumors, the seizures may happen. Okay, so that's one of the precautions that we should take during the physiotherapy management. What are the assessment that we should do, and what are the indication contraindications? So pre-operative assessment include we should define the post-operative or a baseline after operation. What is the current function level? Okay, that is what we should define. We should identify the medical risk or anesthesia risk. We should plan a approach. Okay, perioperative care during surgeons will plan an approach which surgery is to be done, and ultimately plan a rehab for a appropriate rehab. Okay. So what are the pre-op assessment? Assessment includes the neurological exams like GCS, motor, power, tone, deep retinal reflexes, superficial reflexes, the cranial nerve examinations. You have already learned during the physiological practicals in second and first sem. Functional baseline, that means bed mobility, balance, gait, ADL's dependence is how much. Okay, and medical fitness, like what are the vital organs functions and what is the nutritional status. Okay, the indications of surgeries are raised ICP, seizures, any progressive neurological deficits, that means patient will be worsening day by day or hour by hour, and hydrocephalus is one of. So these are the broad classification of indications. Contraindications, like surgery may be avoided in a poor medical condition, inaccessible tumors, advanced metastasis, or bleeding disorders. If at all, if it is there, no surgery should be done and patient should be managed conservatively. In tumor surgery, what happens? It involves the craniotomy, tumor removal, bleeding control, and closure. And CSF diversion may be needed, like you have seen that cranioperitoneal drainage, right? So bone will be opened. There will be a safe corridor exposed. Tumor is exposed. The partial or total removal of the tumor will be happening. Bleeding control or a hemostasis will be achieved, and again the bone flap will be replaced. Okay, if the swelling is more, the bone flap will be removed. It can be, in some cases, it can be stored in a ASIS region, that is um ischial part. Okay, it will be preserved inside the pelvis, or in some cases it can be permanent. In those cases, no need to preserve a bone, because there will not be any needed to, it will not be needed to reattach to the skull. Okay, in those cases it will be removed and excised. What can we do? Let's see that. So if the pain which will limit the breathing, movement, rehab participation, and it includes an acute postoperative neuropathic and spasticity related pain. Okay, that these are the types of pain. So let's see about the acute. Physiotherapy will manage pain using the positioning, breathing control, pacing activities. Pacing activities meaning patient is using or moving the body or doing a function at his or her own pace or at own rest or speed. Okay, that means pacing. And coordination with the analgesia, with the help of analgesic drugs or analgesic treatment, with physiotherapy management like TENS or IFT or whatever. With that, patient reduces the pain or limits the pain, and with those time duration, patient will be introducing the exercises. So during with less pain, patient can do exercise. Okay, so that is what is management. Neuropathic pain, it represents as a burning, electric shock-like pain, allodynia, and hyperalgesia. Okay, allodynia meaning light touch, even a light touch will cause a pain. Hyperalgesia meaning increase the pain response, even if you have given a very small amount of pricking sensation or any pain stimulus, but that will be aggravated and it will be felt more by patient. What are the non-pharmacological management? Non-pharmacological management like physiotherapy management without any drugs. Non-pharmacological include the reassurance, desensitization, tense, pain control enables the movement, and movement enables a recovery. Okay, this is what is the uh, here we are completing the neurological disease and the surgery physiotherapy management. Ultimately, we had covered broad things like head injuries, head diseases in children like spina bifida and hydrocephalus. We had covered congenital disorders of children like spina bifida. We had covered a trauma like where neuropraxia occurs, where exenotemesis occur or neurotemesis occurs. We had covered brain injuries, trauma. We had covered peripheral nerve injuries like claw hand, ulnar claw hand, median nerve injuries, radial nerve injuries. We had covered entrapment syndromes like CTS, cubital entrapment, right? So these are the things that we are covering. We have covered the tumors of brain. We had covered the tumors of spinal cord and its surgical and physiotherapy management. Ultimately, consider when a neuropathy is there, that means in case of spinal cord injuries and in case of peripheral nerve injuries, there are common physiotherapy approaches that you can list out. Okay, you can go through the PPT again. You can go through the books, which I am telling you. Darcy, one of the neurological examination and physiotherapy management. Darcy book is good. Cash book is good. Okay, you can refer Kishner also, and these books will give you more insight about the physiotherapy management during neurological disorders. Okay, so there are common techniques which will do, like how to do a gait training, how to perform active movements, passive movements, active assisted, how to plan resistance movement. Okay, so these are the insight that you should have an idea about. Chalo, thank you.